In this training video, we'll talk about behavioral strategies for preparing children for medical, dental, and personal care, such as haircut appointments. And we're very fortunate to have Dr. Keith Allen. Keith, would you please tell us something about yourself, how you got interested in this particular topic also?
I'm a licensed psychologist, pediatric psychologist here in Nebraska, trained as an applied behavior analyst originally at Western Michigan and then West Virginia University. Did an internship down in Mississippi and now been here for about 28 years at the University of Nebraska Med Center and the Monroe Meyer Institute.
Keith, one thing that parents of children on the autism spectrum and with other types of developmental disabilities often finds challenging is preparing your children to go to a medical or dental or a personal care appointment, such as a hair appointment. Could you talk a little bit about why that's an important topic, and in particular how you got involved in that particular line of clinical and research activity?
Sure. I first got interested in that when I was at West Virginia University. They had a dental clinic there, and they came to a professor in psychology and said that they were just having lots of difficulties with some of their kids in the dental clinic in terms of disruptive, uncooperative behavior, and it was getting to be a safety problem for some of their providers. And they asked one of the faculty to come up and give them some help, and I happened to be a student of one of those faculty, and that got assigned to me, which was great experience, not only in dealing with kids who were very fearful and engaging in a lot of avoidance behavior for pretty intense procedures, getting teeth pulled out and restorations, but even simple, just teeth cleaning and just getting in there and taking a look around was proven to be real difficult. Because of the nature of some of the instruments, you've got drills and injection needles and sharp objects. It ended up being a real safety issue for the kids, safety issue for the staff, and then ultimately a health problem. Kids who have poor oral hygiene not only end up having problems with their teeth, but there's now increasing evidence that as people get older, if they have poor oral health, there are other health risks that come with that, including cardiovascular problems, strokes, and heart disease, which sounds crazy. Like, can that be possible from simply having bad oral health? And well, yes, it can.
Keith, are the problems that we're talking about more common for children on the autism spectrum or those diagnosed with developmental disabilities? Or is it something that cuts across the whole spectrum of children, including neurotypical children? And I'm kind of asking because I'm wondering what role language capabilities plays in all of this. Is that a real important thing that makes a person perhaps at greater risk for having difficulties going to a dental or medical procedure?
Yeah, I think it's more common in older age individuals with disabilities than chronologically age-matched people. But as you get younger and younger, even in typical individuals, it's a pretty significant problem even in kids who do not have developmental or intellectual disabilities. A lot of that, I think, is hardwired into us. There's very clear evidence that certain types of unfamiliar stimuli, unfamiliar sensations can elicit fear responses, and they progress fairly typically. So even in young kids, masks, strangers, separation from parents, novel stimuli elicit fear responses and evoke avoidance behaviors. Those just start to become less of a problem as kids get older and like you said, develop language skills and better coping and tolerance. And those just don't develop as quickly and sometimes not at all in individuals with disabilities.
Keith, some of the procedures we're talking about have some inherent risks, either of going through the procedure or oftentimes inherent risk if you don't go through the procedure, and you really need to go through some of these procedures. But the other part that I should also mention is that some of the procedures have some inherent pain associated with them.
Absolutely.
For example, if you have to get a shot or something of that nature, or if you have to have a tooth drilled or surfaced or something of that nature. I would imagine that the pain that's inherent in some of these procedures may contribute to the development of anxiety or phobias. Do you have any thoughts about the role of pain and how to help children cope with pain as they experience some of these procedures?
Well, yes, to answer your first question, yes, a lot of these, especially medical and dental procedures the terminal event has some real pain associated with it. So although initially some of the fear responding is created by just the novelty of the stimuli, the unusual sensations that are associated with that, ultimately there's some discomfort involved.
Keith, as you've described it, it sounds like children on the autism spectrum and those with developmental disabilities are at elevated risk for developing some challenging behaviors or some fears or anxiety about medical, dental, and even haircut appointments. I'm wondering if you talk a little bit about how these people come to you seeking help and what sorts of assessment questions you might have to help you formulate a kind of a behavioral conceptualization of the problem and lead you towards treatment strategies.
Okay. One of the first things we do, I guess, which would be kind of a limiting circumstance, would be how important or critical this procedure is to get done right now. So there are some medical procedures that they don't afford you a lot of time to create a program to help somebody gradually develop skills to tolerate the procedures. And if it's something that needs to be done right now, we might say there's a limit as to what we can do with this. But if there's not an immediate need, an emergency need for the procedures, then we can say, okay, there might be something that we can do here to contribute. We would go then and typically try to look at the situation and do some direct observations and see at which point problems are starting to occur. We do a task analysis to see what aspects of the procedures, what the typical sequence would be, and where the problems start to occur. And then we do some assessments to try to figure out what the probable function of that behavior is. I will say that in almost all of these cases, the function is escape, to avoid the unpleasant or unfamiliar or uncomfortable aspects of the stimulus. But it still pays to pay attention to that and ask questions to try to get at what we think is likely the function here.
Keith, it sounds like there's a whole sequence of stimuli and responses that are involved in going to a dental appointment, for example. Everything ranging from scheduling an appointment to getting dressed, to getting in the car, to driving to the dental appointment. And I'm wondering whether or not you sometimes get resistance and fear behaviors associated with this whole range of events that transpire before you make it to a dental appointment, or do the fear responses typically emerge solely when you get to the dental office?
Yeah, I mean, we have individuals that can't even get out of the car or won't even get in the car if they know where they're going to and anticipate the procedures that might be involved. Others that can get in the car and ride all the way and walk into the waiting room and maybe even come in and sit on the exam table, or if it's getting a haircut, can get all the way in there and sit in the chair. It's just when the tools that are going to be involved appear, you start getting problems. And so the assessment involves asking parents and providers, and then maybe doing some direct observations to see the point at which you start getting real marked avoidance behaviors. But also looking for early precursor signs. So you may not see somebody actively avoiding, but you're starting to see maybe they're vocalizing complaints earlier in the process, and you're going to want to start your intervention back probably at that point, not waiting all the way to where they're starting to really put up a fight.
Keith, it sounds like there's a whole constellation of behaviors that get involved in this response class that you might be observing for children that are resistant to or fearful of dental appointments. Can you talk a little more detail about the range of behaviors that you might be looking for as indicator variables that you have a problem going on?
Sure. In the vocal and verbal category, you could have crying, you could have moaning, you could have complaining. In the physical category, you could have obviously resistance even going into the exam room, but you could have hands that are coming up and blocking, face turning away, leaning back. Those would probably be the most common one. For many individuals, there are probably some private, harder to see events that are going on, heart rate going up, sweaty palms, dry mouth. And sometimes we do have instruments where we can monitor that, especially heart rate. But usually there are a lot of other signs you've seen before. You can get that connected to somebody and actually monitor that.
So Keith, for the practitioner, it sounds like you don't really need to do much in the way of physiological monitoring, do you?
Probably not. Probably some of those just outward vocal and physical signs are going to be enough.
So Keith, it sounds like you get a pretty good descriptive analysis of this whole sequence of stimuli and responses that lead up to a medical, dental, or haircut appointment. What do you do next? What are the next steps for the practitioner in terms of formulating either further assessment or developing strategies to monitor progress or even developing intervention approaches?
Okay. The place you're usually going to start is you're going to start by creating what we call a hierarchy of steps in the sequence from very low demands on the individual, something the person is likely to be able to tolerate relatively easily, and progressing up with steps that are increasing in their difficulty for the individual. So the sequence of the hierarchy might not match the sequence of the actual medical or dental or even hair cutting procedure. You might need to reorder things so that the initial ones are ones that are fairly easily tolerated, and then you progress. And depending on the individual, those steps might be very, very small steps to ensure that they can tolerate those fairly easily. Some individuals can tolerate bigger steps in the sequence so that you can move a little bit more quickly through that hierarchy.
So Keith, it sounds like the hierarchical sequence may not be in a very obvious linear fashion. For example, it sounds like it may be more difficult for some kids to get in the car than it might be to actually go into the dental office, for example.
Absolutely.
So am I understanding correct that you want to simply look to see which ones are the most anxiety producing to develop your hierarchy, and in some ways, I guess, ignore what the temporal sequence looks like in favor of the level of anxiety that's produced by the sequence?
Yes. Yeah, work your way. So you want to start with ones that are easily tolerate, almost to the point where it's not a problem at all, to start with that item and get some success. One of the things you're trying to accomplish ultimately with these procedures that's critical is exposing the individual to the feared stimuli. This is the core of the treatment, is an exposure protocol, but creating a hierarchy in such a way that you're not generating a lot of avoidance behavior. Because you don't want to have to resort to escape extinction if possible. And it's not that you would never use that, and in the literature sometimes people do, but it is not the core feature of a good treatment protocol. The core feature is exposing to the feared stimuli in a graduated fashion that allows the individual to successfully tolerate those without resorting to a lot of avoidance behavior.
Keith, you mentioned escape extinction. Can you describe what that is procedurally for those, especially the clinicians who might not have a direct experience with that particular procedure, and why it might be contraindicated, Keith?
Mm-hmm. Yeah, escape extinction is basically when you understand that the function or purpose of the behavior is to escape, to get away from these unpleasant or unfamiliar or painful stimuli. One treatment approach in some situations is to not allow the person to escape when they engage in inappropriate behaviors. On the flip side, you might try to create opportunities to allow them to escape instead for appropriate behaviors, and that piece we will use. But the blocking them or preventing them from escaping when they're being disruptive is escape extinction, and this just creates some real risk problems itself, because now you're holding somebody down, again, creating some risks for the individual client or child or person, risks for the staff that are engaging in this, and we want to try to avoid that.
Does the defining feature of escape extinction, that is preventing a person from escaping a situation that's anxiety-provoking or fear-provoking, does that sometimes add to the fearfulness they have in that particular situation?
Absolutely.
I mean, for me, I would find it very scary to be held down and prevented from escaping something I wanted to avoid.
Yes, and so we're usually working to avoid that. In fact, if we get in situations where there's escape behavior that we're even thinking to ourselves, gee, should we block or stop this? What I start thinking is that we have not created a good hierarchy, that we've taken too big a step. We need to back up with smaller steps that allow this person to tolerate without resorting to these types of disruptive avoidance behaviors.
Keith, you've talked about doing an interview with parents and maybe even some observations of the situation and the behaviors that are associated with some of the fear responses. But we haven't talked about the kind of the overview of the comprehensive treatment model. Can you give us a little orientation to this whole range of things that might go into a comprehensive treatment plan for dealing with fears and avoidance behaviors in dental and medical settings?
Yeah, absolutely. I mentioned probably the core components are going to involve exposure to the feared stimuli and a graduated approach to this exposure process. So creating a hierarchy of easy to gradually more difficult exposures. And that's the core feature of all treatment programs. If you look in the literature, this is similar across all studies that have found good effects. Then there are some other features that people will add in to help enhance the effectiveness of that exposure routine that you're going through. Commonly, this would include some type of contingent reinforcement so that once the individual has tolerated exposure and handled that well, usually by laying still and not engaging in a lot of avoidance behavior, then there's some type of payoff for that, some type of reward that's delivered. So this would also require in the assessment process that you're doing some effort to identify what are some probable reinforcers for this individual. That could just involve interviewing the parents, could involve interviewing the individual themselves, might actually involve a preference assessment more formally. Doesn't necessarily have to involve that, but it might involve that, so that you have a good sense that when this person has tolerated exposure, the thing that you're going to deliver is going to be valuable to them. In many situations, the most valuable thing you can offer contingently is escape. Now, that doesn't mean you let them get up and go home, although sometimes you do, but this could just be breaks from the ongoing procedures. And there's pretty good evidence that even brief breaks from the ongoing procedures can function as reinforcer. It doesn't have to be extended breaks. 10 to 15 seconds can be a meaningful break that will function as a reinforcer. So a lot of times, that's the reinforcer we're delivering, are breaks. But there might be other things. We not only allow them a break, but they might sit up and play with a little video game for a little bit. We might give them a little token that can then be cashed in for money. Might use a tangible thing like a food item, although probably not in the dental clinic. We don't want to be shoving food in when we're trying to get food out.
Yep, right.
So you have that piece, the contingent reinforcement, and that clearly views a lot of the avoidance behaviors as an operant event. I do want to point out that there's also some value in thinking about using access to reinforcing activities or stimuli non-contingently in anticipation of these exposures. This has a little bit more of a respondent feel to it. Some people call this counter conditioning, but the idea here is that by allowing the person to engage with something that they find reinforcing, this tends to have a relaxing effect. And if you get the person relaxed and they're engaging with something that they're comfortable with, then the exposure process goes easier. Okay? This inhibits the fear response. So we might have somebody bring something that's very familiar to them and helps them feel comfortable and sit there and get comfortable before we start the exposure process, and then deliver other types of reinforcers contingently. So you could use them on both ends. This isn't always used, but is worth thinking about. So again, you're trying to avoid getting into a situation where the individual will crank up a bunch of avoidance behaviors. The graduated exposure is the primary way you do that. Contingent reinforcement can help. Also, delivery of some non-contingent reinforcing activities that they just get to keep with them and have available can also help that process.
Keith, by non-contingent reinforcement, just for clarification, you mean a source of reinforcement that's delivered independent of behavior on a time-based schedule, like every 5 minutes, or maybe it's just something that they could simply have the whole time, like a favorite blanket or something that's soothing that they would have access to the whole time they're there.
Doesn't even have to be delivered on a schedule. It can just be, it's available to them and they have it with them. Mm-hmm. So we might, as an example, have somebody, and parents can arrange these opportunities also, they come to the clinic and they bring their favorite things with them, and they're not exposed to any really procedures at all. They just come and get to be in the clinic in a relaxed opportunity. They have relaxing things with them, they get kind of comfortable there, and then they go home. These would be some early counter-conditioning things we might encourage parents to do. Look, you don't even have to come here and see the dentist or see the physician. You could just make some trips and get comfortable with coming in, visiting this waiting room with things that are available to the person that make them feel comfortable, and then they go home.
Keith, this sounds like an interesting strategy to prevent or maybe preempt the development of some serious resistance and fear responses. I'm wondering if dentists are pretty amenable to this sort of intervention so as to prevent the development of fear and dental resistance behavior.
They are amenable to it because it doesn't cost them time, and they don't get paid for their time, they get paid for procedures, so they don't have to interrupt procedures that they're doing. So the idea of people making preemptive visits without any work being done is a really good idea. Now, unfortunately, a lot of people don't go to the physician or the dentist until the work needs to be done. But if people wanted some recommendations about how to potentially head off problems with their child or person that they're providing care for who has disabilities, I might think, well, anticipating at some point they're going to need dental care and at some point they're going to need medical care, making trips to those clinics where no work is getting done, and they just go there and have a fun time, meeting people there, getting familiar with the environment, doing it in a relaxed fashion, and then going home. Great way to head off potential problems.
Keith, that sounds like a marvelous strategy. You also mentioned using escape as a reinforcer for appropriate behavior. And since we're talking about it, do you also sometimes recommend non-contingent escape?
We do. We've had very good experience in the dental clinic, both with therapists like ourselves, giving kids lots of experience with the idea that escape can come for free. We've trained some dentists to do that also. It's a little bit harder for them to do. Medical providers and dental providers are just a lot more likely to use escape contingently on problem behavior because to them safety is a concern. So when people start getting disruptive, the dentist and medical provider will stop and try to manage the situation. And ultimately we'd rather not see that. And on the flip side, have them give breaks when the individual is coping well. That's something providers don't think of very well, but a technician, behavioral technician, a therapist should be able to think of that a lot and add that as a part of their treatment procedures and have very good effects with that.
Well, Keith, that's an interesting perspective. The basic notion that the providers might be giving escape contingent upon disruptive, complaining, or other types of behaviors. Do you think there's a chance that that might inadvertently contribute to the development of problem and resistance behaviors on the part of the child?
Yeah, I'm quite sure that it does contribute ultimately to problems, but you understand why providers need to do that for safety reasons. One of the interesting things we've found in some of the research we've done here is even if the medical and dental providers are delivering escape sometimes for problem behaviors, if they also deliver it on a fairly rich schedule for the absence of problem behaviors, we see less problem behavior.
Interesting, that's a good point.
So we don't have to really harp on the medical or dental providers to stop giving breaks for problem behaviors. We understand they've got some obligations to keep things safe, and they're going to do that, and we can just leave that alone and remedy that to some extent by making sure we're providing breaks on the flip side when the individuals are coping well. We might have to prompt them a little bit with that or do it ourselves, but it can be effective.
Keith, you mentioned something about the tendency of dental and medical professionals to give breaks when the child is being disruptive or complaining. I'm wondering if you could think along the lines of replacement behavior that might not be as disruptive but might still indicate that I need a break. For example, training the child to raise a finger or to press a button or to do something else that would be not especially disruptive but would still indicate that I need a break.
Yeah, that's actually not a regular part of our protocol because frankly most providers do that pretty well anyhow. A lot of them have kind of learned in their training that And they'll tell the individuals, give me a little signal if this hurts or is uncomfortable and I'll stop. But the fact is that medical providers don't really want to do that, so they don't reliably respond to that little safety signal, so it doesn't function very well.
So it just to me, Keith, makes sense that you try to train the child with an easy response to say, I need a break, of raising your finger or pressing a button or something like that. And that just seems like it would be an easy thing to build in, at least that's my opinion anyhow.
Yeah, yep.
So Keith, what other procedures would you build into a comprehensive treatment package? And let's talk about those before we begin to focus our attention on developing and using a hierarchy.
Okay, now I'm going to mention a couple of additional strategies that people might use. They aren't commonly used in the research literature as much as the exposure, the graduated approach, and then the contingent reinforcement are the three most common features that you'd want to make sure you included. But some other things people might do is include modeling, so that the individual who is being asked to tolerate these procedures gets to see somebody else tolerating them. And that could be the provider themselves. So if I picked up an instrument and I show that I can tolerate these and I can touch my fingers with the instruments or my own face with the instruments or my hair if it's a haircut, you might bring over a peer or a sibling or a parent and allow them to model tolerating exposures before the individual is asked to tolerate that exposure. That can be a fairly useful strategy, and sometimes people will put these modeling elements into a video and allow somebody to watch the video before they even come to the clinic and see somebody else tolerating these procedures. Again, that isn't used as much as just the basic exposure, direct exposure, but these can be effective little elements that we might add in here and there.
Keith, if you use a modeling procedure, are there any special pointers or guidelines you have for what goes into a video model? Is it important to have the model in the video show that they're successfully coping with the procedures? How about, is it important to have a model of roughly the same age or maybe even the same gender as the person to whom the modeled video is being shown? Are any of those things important, Keith?
Yeah, I mean, the literature in modeling would generally suggest that the more closely the model matches the individual who's watching, the better the outcomes would be. So you like to try to match on some characteristics like age and gender and perhaps race, but that's not critical. So that if I didn't have a peer available either in person or on video, and I'm using a parent or a teacher or some person that's familiar to them, that could be just fine. Stranger might not be as valuable as somebody that's familiar, but those are things that you could pay attention to. But I wouldn't spend a whole lot of time focusing on that when we know that the core feature is direct exposure to the stimuli in a graduated fashion with some type of contingent reinforcement. So I am adding in these other things that we might use, but I don't want to distract from what the core features are.
Keith, it sounds like modeling is a pretty valuable adjunct. Are there any additional supplemental procedures that you'd like to talk about that should go into this mix of comprehensive treatment package?
Sometimes people will use distraction. Okay, distraction could be something as simple as a video of a favored movie that's playing up on a TV screen, music that's playing that's familiar to the individual, and they can wear some headphones. My one concern about distraction is sometimes distraction gets in the way of the individual actually being exposed to the stimuli. So, for example, nowadays you can actually get video eyewear that are goggles that you can put on and watch a movie. They're goggles that actually fit over your eyes. Well, it's really nice in the sense that it really blocks out stimuli in the environment, but remember, the core treatment is direct exposure to the stimuli in a graduated fashion so that you can learn to tolerate those. So if the distraction is actually blocking you from exposure to those stimuli, you're missing the core treatment. So these are just some important things to keep in mind. It doesn't mean I would never use a distraction, but not very often if it's blocking what I want to be doing with exposure.
That's interesting. I'm wondering if distraction sometimes gets in the way of cooperative behavior also.
Yeah, so another problem could be that the distractors themselves actually interfere with the medical or dental or healthcare procedure that you're trying to implement. So in the process of helping, you're actually creating more problems than you're solving with the distraction procedure itself.
Well, Keith, it sounds like that video modeling or some type of modeling plus distraction are very valuable supplemental procedures that we might build into this treatment package.
No, I think that gets to most of the procedures that people might use in some part in creating or enhancing the exposure procedures that you're going through.
Okay, great. Keith, you talked about wanting to reinforce a range of appropriate adaptive coping behaviors on the part of children, perhaps reinforcing with either social praise or even a tangible reinforcer or maybe a break from a procedure. Can you give us an overview about the range of appropriate behaviors? What falls in this response class of appropriate behaviors that you would like to encourage?
Well, the types of behaviors that we're looking for that we'd like to signal escape or that they are tolerating well are calm, quiet behaviors. So the legs aren't moving, the hands aren't moving, the person's not complaining or crying or fussing or making a bunch of escape comments. That's the ideal. And what we'd like is that the technician and ultimately the provider recognizes those and delivers reinforcers contingent on those. And reinforcers could be praise, could be escape itself, breaks from the procedure. One of the problems with that is that providers often don't recognize though because it's a passive response. I mean, nothing's happening, and providers tend to, when nothing's happening, think, great, I can get more work done. And that's logical because they get paid for getting work done. They don't get paid for their time. They get paid for procedures. So this training providers to be vigilant for passive behavior as the thing that you want can be challenging. One way to get around that is to teach the individual an active response that is a safe behavior that doesn't interrupt the procedures but indicates to the provider, I'd like a break. And that could be signaling in some way. In dentistry, they often have the individual just raise a finger so that they don't make a verbal response because often the dentist is in their mouth. But it could be raising a hand, it could be touching a card that indicates they'd like a break, and there could be an active response that you would teach. This is not typically an approach that's used in the published literature, but it makes a lot of sense and could be really appropriate for some individuals to have not just a passive response that you're working on, but also an active alternative that they could use.
That to me sounds like it might be an interesting procedure because many children on the developmental disabilities or autism spectrum have language difficulties, and some of them have learned to use sign language or even a pointing response such as a bliss board or a PEX icon as a way to interact with and request items in the environment, including perhaps breaks. And I'm wondering if that might be a fairly easy procedure for many of these children to bring into a dental clinic or a medical appointment or even a hairstyling appointment.
Yeah, that's a really a good point, that if they already have an escape response that's appropriate available in their repertoire, then why not take advantage of that?
Okay, sounds great.
Yeah.
Keith, you've explained a number of components that might go into a comprehensive treatment package. Those all sound like they make good sense. I'm wondering if we can now kind of get you to comment in more detail about the exposure process and the response prevention process and how that would actually be implemented in a dental setting.
Sure. So once you have created your hierarchy, so the first item at the bottom of the hierarchy, which is going to be the easiest to tolerate, you're going to start there. And what you're hoping is you've selected a step where the probability of the individual tolerating is very high. And then you're thinking, okay, what's my success criteria going to be for moving to the next level? Oh, there's a lot of different success criteria that you could create. A common one might be, I'm going to ask for 3 exposures. 3 consecutive successful exposures, and when I have that, I'm going to feel like that's a mastery level, and then I'm going to move on to my next step in the criterion. So for example, if we were in the dental clinic and we were at a point where an individual has learned, we're going to start the protocol at touching their face with an instrument. And we're thinking about, we don't want to be putting things in their mouth right away. We can see they can't tolerate that. They might tolerate opening their mouth and getting it close, but not great. But tolerating touching the face, we think they can tolerate that pretty well. So we might take our instrument, model for them being touched either with their mother or with ourselves, and then touch their face, give them a little break, give them some verbal praise, nice job with that, oh, he did such a good job, and then we come back and touch again. We get 3 of those, and we think, great, we've got mastery on that. Now we're going to move closer to the mouth. The next step might be touching the lips. Next step might be touching the teeth. The hierarchy, in creating the hierarchy, you have to think there's all sorts of parameters that might be relevant here, and the one I just mentioned is a proximity parameter, but you also could have pressure parameters, so touching the face isn't the same as touching and pushing. Duration parameters, so I might touch the face for just a second, but I also need to have the individual learn to tolerate longer durations of touching. And I might do that initially outside the mouth before I get in the mouth. Once I'm in the mouth, not only do I have the proximity and the pressure and the duration, but I can have the quality of the sensation. So they're going to feel vibrations. They're going to hear sounds that go along with that. And these are all things that a good technician will have thought about ahead of time in creating the hierarchy. The one that's easiest is proximity. Everybody tends to think of that first, getting closer and closer to the stimuli, to contact with them. But you have to think about other aspects of that. And common ones in medical procedures is not only proximity, but pressure and duration would be other common ones that we might use.
Keith, those all sound like important elements of a hierarchy. I'm wondering if anybody's ever experimented around with control as an important dimension. For example, allowing the child to control the instrument and touch his or her face, and whether that's a easier to tolerate procedure for a child if they have some level of control over the sensations that they're feeling.
Absolutely, yeah. You might, well, just having said that, in terms of thinking about who's presenting or doing the exposures, you also need to think not only about the stimuli that are specifically related to the procedure itself, but stimuli associated with the people who are doing the exposures. Just as an example, for young kids and many individuals with developmental disabilities, people in masks elicits fear, evokes a lot of avoidance behavior, especially if the person in the mask is an unfamiliar person. So you might think about that as part of your hierarchy, is thinking not only about the stimuli themselves, but the people providing them and what they look like. Delivering exposures when you're behind somebody might not be as good as being in front of them. This would be true with a haircut. Having somebody who's strange behind you using instruments you're not familiar with might elicit fear and avoidance behaviors more so than somebody who's in front of you and is familiar and has instruments that themselves are also familiar. So these are all things that we might pay attention to. And I brought some stimuli to show you as an example.
Sure, show us some of those, Keith.
Yeah, so I've got, here's just an example. Let's see, I'm going to pull out these, all 4 of these. Here's a common mask that a medical provider might wear and increasingly are required to wear. And frankly, to a lot of young kids and even older ones with developmental disabilities, this is a scary proposition. Even if the person is familiar, this is very different than this. We might need to do some graduated exposures related to tolerating people with a mask. But initially, I would think that the trainer would not have a mask on, and I might not have the dentist. I might have a trainer who's familiar to the student. I might think rather than using this tool, which has very sharp ends to it and looks kind of scary, or this one, which is a little less scary but unfamiliar, I might start with a tool like this, which looks real familiar, and do exposures with, if I can get my hands oriented, with this end of the toothbrush. And a child might already have exposure to that and being associated with unpleasant types of experiences, so I might flip around and use this end on the face, then the teeth, maybe then within the mouth, creating real safe, easily tolerable exposures before I then move to something a little bit more difficult and then something a little bit more difficult. Yes? But some of the stuff dentists wear, they're scary. Not only do they wear this mask, but they'll wear glasses that have magnifying glasses, and it looks weird and scary. And then on top of that, you're asking, well, this is one problem with exposure routines. There's plenty of times where the individual is asked to tolerate more than any single instrument. They're asked to tolerate several instruments in their mouth at once. So they've got a mirror that's in there, and they've got a suction device that's evacuating material, and they've got some other type of tool that's in there. And it's just a lot of stimuli all at once. And on top of that, they're looking at somebody who's in a mask and has magnifying glasses, and it's not very familiar to them. And well, of course people try to escape that environment. It's totally predictable.
Keith, I understand the problem with masks, but what do you do? What do you recommend to the dental or medical professional? I mean, those masks are there for their protection and for the well-being of the person they're working on. Do you perhaps recommend that they start off with the mask off and only gradually add it on, take it off? How do you cope with the mask and getting some sort of a adaptation response to the mask?
They are. A lot of these things are there for protection and also to enhance the provider's ability to provide quality care. So, I mean, they're wearing these magnifying glasses so they can do precise work. What you'd like to have ideally is that the individual's first exposure to this individual is not with all of that equipment on. So I'm going to go back to the ideal situation is that, you know, parents or care providers show up at their pediatrician or at their hair salon or at their dentist in situations where it's not an emergency, where they don't have to get these things done. And let's say the next level, well, it's not an emergency, but care is going to need to be provided. And we might say, well, let's do some anticipatory trips where we go and we know on this trip we're not going to be doing actual care. We're just going to get to know the provider, hang out with them a little bit when they don't have a mask on and they don't have any of these instruments with them, so that the environment where the care is going to be provided is familiar and they've had some relaxing and comfortable experiences there, maybe had some other reinforcers delivered for tolerating sorts of behaviors that appear in that situation. That would be the ideal. Now, of course, for us, usually that wasn't done, and by the time the client shows up for us, it's either an emergency or close to it, or they've had a long history of a lot of avoidance behavior and having that behavior be pretty effective. So we have to go back and create lengthy hierarchies that give them successful experiences.
Okay, Keith, you've talked about establishing a hierarchy and the notion that you have to lead people through them, getting exposed to each of the steps in the hierarchy. Is this a pretty easy process, or do you sometimes encounter steps that are very difficult for the kids to get through? And if you do, what do you do under those circumstances when the hierarchy progression is not nice and smooth and easy?
Yeah, you do sometimes create the hierarchy as best you can, and then realize as you're moving up it that you didn't anticipate that next step being that difficult. Your assessment was just wrong, and that happens. It might be that you didn't anticipate that the sound of one of the instruments that's going to be used, or some stimulus aspects of that, are now evoking all sorts of behavior you didn't anticipate. Of course, once that behavior shows up, you're stuck dealing with it. That invites, do I use escape extinction? Our thought would be, usually we would try to avoid that, and we'd try to back up to an easier step. The classic way exposure protocol might work is you just back up to the previous step that was successful, but sometimes we might even just on the fly back up several steps just to guarantee we're hitting some success, and we might move right back on up the hierarchy, but then have thought, okay, that step that was a problem is going to need to be moved up higher in the hierarchy, and insert something else that can be the next step. But it might be that we don't need to move that step further. It might be that we just need to do more gradual exposure to that step.
Keith, I'm wondering if you sometimes alter the duration of exposure to a step in the hierarchy, or do you even sometimes train a coping response, maybe like a relaxation response, to help kids get through each of the steps in the hierarchy?
Although we don't make a focus trying to teach an active relaxation response, this would not be an unusual thing to do. So you might teach an individual a slow, deep breathing response that they could use. You might teach them a little tense and release behavior that they could use. And in fact, interestingly, some dental schools do teach their providers to do this, to give the kids a little procedure where they point their toes really, really hard as an alternative response when they're going through some procedures. And that's actually a really cool idea. They don't actually do it for the same reason that we would do it, but there can be some coping responses like that, making a fist and squeezing hard, slow, deep breathing, pointing your toes. Sometimes parents are actually in the room, and we might teach the parents some things that they can do also. Saying distracting things, getting the kids to think about some fun, pleasant things that are familiar to the kids could be a useful strategy. Sometimes it's a little tricky getting parents involved at that point. Parents tend to drift towards saying lots of reassuring things, and there's some evidence that saying lots of reassuring things doesn't help, actually kind of gets in the way. There are some studies comparing parents there with parents not there, or care providers there, not there, and generally, if the provider is there, it's either better to have them say nothing or say distracting things. But those could be alternative kind of coping tools that might be involved.
Keith, if I'm hearing you right, it sounds like you aren't involving the parent in the acute exposure process, but I'm wondering if there's another role for the parents. Are you trying to get them involved in some of the sort of preventative, preparatory activities at home, perhaps?
Yeah, well, yes, we would try to have the parents involved in getting the kids, again, familiar with the environment so that they have trips there where it's just a good experience and they leave. It's not just related to getting medical care that has uncomfortable aspects to it. We also do include parents and care providers sometimes as models. And that can be very nice because, again, you have a familiar model, and parents are usually pretty cooperative and tend to be pretty compliant.
Sounds good.
So we know that's going to work.
Well, good. Keith, it sounds like a fairly comprehensive package of treatment and prevention strategies altogether. And I'm wondering if you could talk a little bit about the course of treatment. How quickly do you seem to get improvements? What do you monitor to help you decide if you're on track? And what happens if it looks like things aren't working as you thought they would originally? What if you're getting a non-responder to treatment?
Yeah, the course of treatment, usually when somebody comes to us, they've had enough of a learning history that we're not anticipating fixing this in a single visit. We're anticipating we might need several visits to us to address this, where we're and that's just the treatment. We might have some other visits where we're doing assessment. But you're monitoring progress up the hierarchy. So if you're moving across many steps in a session, this is feeling good. If you're having trouble making progress up the hierarchy, I start thinking, well, maybe we don't have this hierarchy set very well. But you might anticipate for somebody who has a lot of avoidance behaviors and a long learning history, we might need 2-3 visits with us separate from actually working with the provider before we then come in and start trying to work with switching from us as the provider to the actual dentist or physician or salon, hair, barber.
Mm-hmm. Okay. So Keith, it sounds like there's variable durations of time that you'd engage in this therapy, a week or 2 weeks or maybe even more. But if I recall correctly, it sounded like there was also one contraindication to doing this behavioral procedure, and that is in those situations where you have a one-time emergency. And it sounds like that in those cases, maybe sedation or some variation thereon is the most appropriate treatment. Is that correct?
Yeah, and sedation is an option when there's an emergency and we don't have the time to go through a good graduated exposure protocol. Another option that some people will use is passive restraint. So they'll use Velcro straps. There's some things called papoose boards, which is a solid board that it then has Velcro straps that people will use sometimes. Ultimately, we'd rather they didn't use that, but because sedation has a lot of health risks, potential risks associated with it, they'd rather avoid knocking kids out and use a restraint type of procedure, and I get that. And ultimately, we'd rather use neither of those and go through our graduated exposures, but sometimes we just don't have the time to get that done.
Well, Keith, I certainly understand the necessity of sedation or some sort of restraint procedure, though one interesting thing is it leaves the children unprepared for their next visit, and you may still have to continue using some sort of restraint or sedation procedure.
Well, let me just comment about the value of, for all of us in understanding how graduated exposure works, is that it just has such wide applications. So the types of places this might come up, we've mentioned several here, the environments, the medical environment, but in the medical environment you have immunization injections, you have flu shots, you have blood draws, you can have throat swabs that you need to do, you have pill swallowing that needs to occur. You could have imaging studies where people need x-rays or MRIs or EEGs, and all of these could be eliciting fear and evoking a bunch of avoidance behaviors that we need to deal with. So graduated exposure would apply in all of these situations, and that's just the medical environment. Personal care, you mentioned hair cutting, but there could be just brushing teeth at home, oral hygiene could have problems associated with it. And of course the dental environment itself has a lot of potential applications.
Are there any side effects you need to worry about?
Well, so this is interesting. You ask about side effects, and although generally I would say the risks are very low, they're not zero. So as an example, we did have we get kids referred to us who don't necessarily have developmental disabilities but are young and so wildly unmanageable that they need a treatment like this also. And we did have an individual once who learned to lay calm and still and be quiet so well that in the process of some dental care, one of her teeth fell out and she swallowed it. I mean, there's some risks, like aspirating that tooth would be really bad. She didn't, but when they took off, they have something that they call a rubber dam, which they put on, which is designed to keep a bunch of fluid from dropping down the throat when they're working on the teeth. But the tooth that fell out was under that and fell out and dropped down her throat, and she never said anything about it, never commented on it. And so I suppose, yes, there are some potential risks that you train somebody so well, they don't tell you when things are hurting, and that would not be good.
So Keith, it sounds like there's an interesting discrimination these children need to learn, and that is how to raise concerns about painful stimuli or procedures that get above a certain threshold of tolerance, but to tolerate those that fall below that threshold and be cooperative under those conditions. Is that what I'm hearing?
Yes. And the dental environment's really unique. In a lot of medical care environments, the really most unpleasant thing doesn't go on for very long. And once it's done, you get to go home. An immunization injection is very short, and then you go home. Flu shots, very short, and then you go home. Even a blood draw is usually at the end of a visit, and then you get to go home. The dental environment's really different because in the typical sequence of events, if you're going to have some oral care that involves an injection, the injection is almost first. And then everything else occurs after that. And the dentist needs to know if that injection didn't quite adequately take care of potential pain. So there does need to be some feedback from the individual about whether that hurts or not. But it just creates an interesting situation. Also, in terms of the hierarchy, if you look at what dentists typically do, the injection is very early in the sequence, but in terms of your graduated exposure, you do not want that injection early in the sequence. You're going to move that way back much higher, or I should do it this way, much higher in the hierarchy.
Mm-hmm. Since you raised the example of shots, let me ask you this. For many years, it was almost standard protocol when you went to the doctor to get a shot that the doctor or the nurse or the practitioner would say, "This is not going to hurt a bit," and then give you a shot. Is that still recommended? Is that still something that's typical practice? And if so, why or why not?
Yeah, I mean, should providers misinform clients about what this is going to feel like? And the answer to that is unequivocally no, they should not misinform. There's some very nice evidence that when people have procedural and sensory information, and that can be verbally provided, but also just through experience, they do better. And that's not surprising. You're talking about exposing them to aspects of the stimulus features that they're going to have contact with, and they do better when they have some exposure to that. So surprising them, never a good idea. And the idea, telling them that this isn't going to hurt, bad idea. Now, it is true that a lot of providers will use euphemisms. This is going to pinch a little, this is going to sting a little. We have no idea what the private experience is going to be like, but to say this is going to hurt, usually providers will avoid that word, and I think that's probably a good idea. But to suggest that there's going to be a sensory experience associated with this is an okay idea.
So if I'm interpreting correctly, Keith, it sounds like some of these behavioral procedures we've been talking about may help people change their pain experience so as to be able to tolerate painful stimuli with less distress.
The exposures themselves, I think I mentioned, not only have parameters of the stimulus itself, its proximity, its duration, its pressure, vibrations, all of those aspects. You also have stimulus aspects of the environment around the person, which would include the person who's doing this, whether they have a mask on, the other instruments that are in the room, and then what you've just pointed out is the words you use are part of that stimulus environment too. And so you might think carefully about the words that you use and the way that you deliver those. And there might be an exposure protocol to the words you use, might be part of your hierarchy.
Keith, since you're mentioning this whole range of sensory stimuli, some people will call it the sensorium that we experience, and suggesting we pay attention to that, let me ask you whether some children on the autism spectrum, many of whom have unique sensitivities to certain sensory stimuli, such as sound, do you have any suggestions as to how you might prepare them for, say, the sound of a dental drill?
If you're asking how do you prepare them in advance of coming in, that's going to be hard for care providers to do because they don't have typically things at home that they could use. And I'm not even sure I'd assign that task to a parent. I mean, we're talking basically here about an exposure protocol. So I'm not sure I would actually ask parents without them being trained to try to do an exposure protocol. But for technicians, yeah, you have to think that sounds can be a pretty potent stimulus, and you are going to want to have gradations related to that. So as an example, the high-powered drill that dentists use, and also is used to apply just fluoride to teeth. Well, I try to make the sound, but I'm not sure I can. But I mean, it's got that type of sound to it. But you can, if you go sit in a dental office, that's operated with a foot pedal, and you can change the volume and pitch and intensity with the foot pedal, and you can think, okay, I'm going to do some gradual exposures to this, get them comfortable with what this looks like without any sound, so that they can handle it and they can feel it on their face and maybe on their teeth without any sound, and then I'm going to gradually expose them to increasing intensities of sound, first of all over here, then moving it around them, maybe eventually on their face and in their mouth, and then I can gradually ramp up the intensity of that sound with the foot pedal that I have. But it pays to think that in many cases, kids with autism, for example, are very sensitive to sound, but there are some that, of course, that are impervious to sound, and it doesn't matter to them at all. So this would be something that you would need to assess. On the front end, is this an individual who seems particularly sensitive to sounds? either intense sounds or sometimes responds to typical sounds as if they're very intense, we'd want to know that in advance.
Well, Keith, that's a marvelous perspective, because what I hear you saying is that there's a lot of individual variability and you need to individualize treatment protocols to the unique characteristics of each individual person within this larger conceptual framework that drives your thinking, but then distill individualized treatment components to that particular person.
Yeah, I mean, I have this idea of matching the exposure protocol to the child is really important. You could probably go online and find some exposure protocols. In fact, I know that you could, and I have some that I'd be happy to share with people, but that doesn't fit any one individual. And the idea that you could have a general exposure protocol that would apply to a lot of kids is probably not a good thought. The idea that generally that exposure means shifting things around, starting with easy and moving towards more difficult, that applies in all situations.
Keith, what else would you like practitioners to know about preparing children to go to medical and dental procedures and even hairstyling appointments and things of that nature?
Yeah, there are some other things. I don't think I mentioned these, but they're worth knowing. There are some just developmentally typical stimuli that will elicit fear in individuals, especially in young kids, but also individuals with developmental delays. I mentioned some of these. Masks would be one. Another common one is loss of support. The idea of tipping over backwards is a common fear stimulus. It doesn't have to be trained in people. So that type of thing will elicit a fear response, and then people will engage in a fear response, and then of course that contacts operant contingencies and people start escaping. But loss of support, masks, high intensity, unfamiliar stimuli of any sort can elicit fear, separation from parents, stranger danger. I mean, these are all just very common ones so it pays to have some knowledge about general child development and what occurs in the normal developmental process with fears, and think that those probably extend well into adolescence for individuals with disabilities and sometimes adulthood.
So Keith, as we're wrapping things up, could you give us a brief synopsis of what we need to know about assessment and treatment of children as they get prepared for medical, dental, and haircutting appointments?
Yeah, I think some key take-home points, and we've hit on this a couple of times, but when we have individuals that are exhibiting avoidance behaviors, and you could call those fear responses, to common medical, dental, personal care types of events, the core feature of what we're going to be doing to try to treat that is an exposure protocol where you're bringing them into contact with the feared stimuli in a gradual fashion so that they can tolerate those exposures successfully, and then come into contact with some reinforcement for being successful. And then only gradually do we increase the demands that we place on them in terms of tolerating. And if you've got those key features, the exposure, the graduated aspect of those exposures, and then some reinforcement for the successful coping, you've got the heart of a good treatment protocol. The other aspects to that, which are valuable, and we talked about modeling and distraction and teaching actually a coping response, maybe some deep breathing or some signaling behavior can be useful, but starting with those three key pieces is where you want to begin.
Well, Keith, you've covered just this remarkable range of behavioral interventions and preparatory procedures to help children cope with medical and dental appointments and haircutting appointments. I wanted to say thank you very much for sharing this information with the practitioners. This will greatly enhance their ability to assess and provide services. Thank you.
You're welcome.
Hey, Ethan. Hey, how are you today? Who'd you bring with you?
I brought my mom.
Oh, hey. What did you guys bring today?
We brought an iPad, a book, and a 3DS.
Oh, those are cool things. What book is that?
Every kid from the library. We got this from the library. We're going to get the actual books.
What games you got?
The game I have with me right now is Screwon Simulator.
That's a great game. Would you want to see some of the cool stuff I have back there?
Sure.
All right, you guys want to come on back? Come on back. All right, you remember all this stuff, right?
Yeah.
Up on the chair.
Okay.
You want to go up or down? Move back.
Sure.
There it goes. Here, let's move it up. You ready? Just blast off to the moon. Here you go. All right. Do you remember all this cool stuff we were playing with last time? Let's see. What I got up here is my space laser. Here, I think you can turn it on with that if you want.
You can walk in and sit in that blue chair if you want.
Yeah, check that out.
Stuff down
Here, you want to play with it? Very cool. All right, and this thing here is my space camera. Wow. Here, you want to smile for the camera? Good one, pal. All right, what else we got here? Where's my stuff over here? What are these?
Cool.
You already got a pair on. Wear your space goggles. How about this over here? Where does this go?
Around like right here, I think.
Why, you want your mom to try it on first, or do you want to try it on?
I'll do it. Is this right?
Yeah, you're all set up. Very cool. Here, Mom, you want to try to put that on?
Sure. On one side.
You almost got it. How's it feel?
Feels good.
Very cool. Let me show you if I got these masks and gloves up here too. Remember these?
I can't see right now.
And I'll show you.
Masks and gloves.
How many do you want?
I'll have the normal amount.
Normal amount. That sounds good. What do we do with these?
I guess we like put them on our faces.
Yeah, let me see.
Some masks.
Turn it around. Yeah, the metal goes on your nose. You have it upside down, my friend.
Oh, I do. There you go.
Looking pretty professional.
Good, dude.
You're looking pretty good. Check this out. I got one too. Maybe your mom can wear one. You don't have to wear this one if you don't want mom. Very cool. What do we do with these?
Put them on.
Let me see those. All right. Here, let me try one on. You're all set up. Very cool. High five. All right, pal. Here, let's take these off. Let me see your goggles. You don't have to wear the mask if you don't want. You're doing a nice job with those. So what did you bring for breaks today? Do you want to use your video games or your
I'll
book?
use probably both for each break.
Both? Which one do you want to start with?
I'm fine with whatever.
How about we start with your book?
Sure.
You did a nice job following directions. Go ahead and get your book. Nice job, pal. Just take a little bit of break, okay? You're doing a great job.
Look at this.
What do you see?
This is just hilarious. This is probably so hilarious. I remember this.
You're doing a fantastic job. What's going on there?
Well, it's the pig stole the pacifier from Nanny. So hilarious. And that's what the pacifier looks like.
Oh my goodness. All right, just a few more seconds with the book.
Okay.
Then I'm going to show you some other cool stuff. Thank you, pal. All right, well, check these out. You know what these are.
Toothbrushes.
Yeah, which one do you want? The blue one or the orange one?
I'll have both.
Well, pick one.
You mean when you catch a your body so if you are making $50 every day. My mom said pick the very best one and you are not it.
Blue it is. Cheers, pal. All right, pal, we can do short touches or long touches. Here's a short touch. 1, 2, 3. 1, 2, 3. And here's a long touch. You ready? 1, 2, 3. 1, 2, 3. 1, 2, 3. Great job with that. There's your toothbrush.
One, two.
Let's do it with mom too.
1, 2.
Okay, so let's try it on your face now. Do you want to use your own toothbrush or do you want to use my toothbrush?
Well, I already did it with my toothbrush, so I think it would be good if I used it with your toothbrush this time.
Okay, here we go. Ready? 1, 2. Good job. You earned a break. Nice job with that, pal. Let's read your book again. Okay, look back to your mom. Nice job following directions. Okay, here we go again. We're going to do short touches on your face. Are you ready?
Okay.
1, 2. Great job with that. We're going to try another one. Are you ready? Short touches on your face. Here we go. 1, 2. Great job. Another break. Go ahead and take a look at your book. Long touch. 1, 2, 3. 1, 2, 3. Now your mom's going to show you on her face. 1, 2, 3. 1, 2, 3. All right, now if we can use your mom's toothbrush on your own face. Here, let me try. Ready? 1, 2, 3. 1, 2, 3. Fantastic job. You get a break, pal. Read your book. Now I'm going to show you how these things work on our teeth.
Okay.
You ready? Remember, we got long touches and short touches. Here's a short touch with my toothbrush and my teeth. You ready?
Yep.
1, 2. 2 short touches. Now your mom's going to try on her own teeth. Short touch. 1, 2. Good job. Now do you want to do it with my toothbrush or your toothbrush?
I'll do it with mine.
Okay, here, let me hold it for you. Ready? 1, 2. Great job! You did a fantastic job. All right, you get a break. Now we're going to do long touches. You ready? Let me see your hand again. Remember, long touches are 1, 2, 3. 1, 2, 3. I'll show you on my own mouth. You ready? You can count out loud for me since I can't count with a toothbrush in my mouth. Ready?
1, 2, 3. 1, 2, 3.
Fantastic job. Now your mom's going to show you the long touches in her mouth.
1, 2, 3. 1, 2, 3.
Great job. Now we're going to try it in your mouth. You ready? Nice and wide. 1, 2, 3. 1, 2, 3. Great job. You get a break. Here we go, pal. I'm going to lean you back for this one. Are you ready? Here we go. Doing a nice job. All the way back. There you go.
Bottom back there. You're
Perfect. Okay. This next thing is my Explorer. Let me see your finger. Remember, we do short touches and long touches, okay?
Okay.
Let me see your finger. We go 1, 2, 3. And long touches go 1, 2, 3. 1, 2, 3. 1, 2, 3. So I'm going to use this one on my mouth. You ready?
Okay.
Short touch. 1, 2, and long touches. 1, 2, 3. 1, 2, 3. 1, 2, 3. Great job. You get a break. Grab your book. All right, you ready? This is my Explorer again, and I'm going to show you how we do long touches in the mouth. Ready? You count for me since I can't
Okay.
count.
1, 2, 3. 1, 2, 3.
Good counting. Great job. Okay, it's your turn. Here we go. Nice and wide now. I want you to lean back for me so I can see. Great job. Nice and wide. 1, 2, 3. 1, 2, 3. Fantastic job. Good job, buddy. You remember this stuff over here, right?
Yeah.
We've got this air. Remember that? We listened to it first,
Yeah, it sounds hilarious.
and then we put it on our hand.
Can
You wanna
I
push
hold
it? Sure.
I'm gonna do it.
Push that button. Good job,
I'm
pal.
fool around with it. I'm gonna spray it on my mom.
Follow
Alright, here we go.
directions, thank you.
Next thing, ready? We put it on our hand, and then we put it on our cheek. We put it on your cheek,
It's actually kind of startling.
and then we put it in our mouth. Good job,
It's
pal.
actually startling the first time.
Okay, let's go back to the air. Remember what we do, we listen to it first, right? And then we put it on our hand. And then we put it on our face. And then we put it in our mouth. Good job, you get a quick break with that, okay? Now remember, this is my new space brush, okay? So we're going to do it the same way. So the first thing we do is listen to it. You ready to listen?
Okay.
Pretty cool, huh?
Oh, it's snuggling. When you turn that on, it turns on like that thing
Right.
over there.
It doesn't hurt at all.
The activator. Okay.
Okay, then you get to hold it if you like.
Okay.
Ready?
How do I activate it? I don't
I
know
do it
how
with
to-
my foot down here. You want to push
Oh.
the button?
Foot. Okay. Where's the button? This?
Yeah. Very good. Nice job. Okay.
Okay, that's good.
Thank you.
I think
Awesome
it's cool around
job.
with machinery.
Okay, so you see that the next thing we do is we just hold it up against our face. It kind of sounds a little bit louder, but doesn't hurt at all. You ready?
Uh-huh.
Okay, here we go. Fantastic job, pal. Great job. Okay, well, I'll put it on the other side, like this.
Okay.
Put it on the other side. Great job. Fantastic. All right, you get a break. Okay, so we'll do it on your face first. On this side. We'll do it in your mouth. Nice and wide for me. Lean back a little bit. Great
You
job.
gotta lay back. Do you need to lay down?
Good job, pal. You get a break. Grab your book. Fantastic.